In this session of Pharmacology World, I will be addressing drugs, vaccines, and other therapies under investigation for the treatment of the novel coronavirus currently sweeping the world, known as COVID-19 or 2019 nCoV. If you are familiar with these videos, you'll notice that there are a couple things here that are not normally present. One is the date, and the other is the disclaimer that's at the bottom of the slide. The date will let all viewers know and get a sense of the timeliness of the information being presented, since fortunes can change rapidly as drugs are being developed and tested in patients. The disclaimer is included because many people are looking for anything they can find to prevent or cure coronavirus, and in some cases are self-medicating. There are many unfortunate examples in the news right now where individuals have become sick or died as a result of taking medications that they think will help them. Thus, I'm not offering any clinical advice here. Rather, this, as with other Pharmacology World videos, is for educational purposes to help health science students learn the basic science about the drugs and therapeutics that they'll encounter in their clinical life. Finally, there is one other thing that you will notice that is different, and that's the inclusion of citations for primary and secondary literature. This was done because of the rapidly evolving nature of this material and the fact that there is a great deal of confusing information coming out. It's more important than ever that reputable, peer-reviewed sources are referenced, particularly in regards to these drugs and therapies that may or may not end up being successful as they progress through phase clinical trials. Before we get into the drugs and therapies, let's look at the virus, the phylogeny, and the structure, and how the virus replicates. COVID-19, aka 2000 nCoV, or 2019 novel coronavirus, is a member of the family of viruses known as Coronaviridae. Coronaviruses in this family are positive-sense, non-segmented, single-stranded RNA viruses that vary in their genome size and their genome structure between the different genus. The structure of the virus is shown here. There are several key components that I want to point out. First, we have the spike protein, or S protein. We have the M protein, or membrane protein. The membrane protein is a type 3 transmembrane glycoprotein. Next, we have the envelope protein, or the E protein. Another key component is what's known as the nucleocapsid protein, and these are proteins that coat the single-stranded RNA. And then finally, we have the single-stranded RNA, or the genomic RNA, shown here. It turns out that the coronavirus uses its spike protein, or its S protein, to trigger the start of replication upon binding to surface receptors found on host cells. The S proteins have two functional subunits, the S1 or bulb subunit, which is involved in receptor binding, and the S2 or stalk subunit, which is involved in membrane fusion. As we'll see in a few minutes, the S protein is of particular importance for our discussion on drug targets. There are a number of mammalian host cell surface receptors and enzymes that serve as docking sites for human coronavirus. Some of those are shown here. For example, aminopeptidase N, angiotensin-converting enzyme 2, dipeptidyl peptidase 4, and sialic acid, among others. So let's take a minute to look at the replication or life cycle of the human coronavirus. What we see here is the coronavirus binding to a receptor on the cell surface. One of the key receptors on human cells, particularly in the lung, is thought to be ACE2, or angiotensin-converting enzyme 2. Binding to this receptor allows the virus to be internalized into the cell by endocytosis. The virus is in an endocytic vesicle, and upon membrane fusion, the viral nucleocapsid is released into the cytoplasm. The genomic RNA then serves as a template for translation of polyproteins. Then, following translation and replication, we get viral assembly. Then, after a series of steps, the virus is released. In addition to the host proteins I mentioned above that act as receptors for virus entry, there are many other host factors that are involved in every step of the viral life cycle. These could, in theory, serve as drug targets. For example, as I mentioned, attachment and entry is thought to be mediated by ACE2. Annexin A2 is thought to assist in translation of replicase and RTC assembly. GSK3 is thought to be involved in genome replication and transcription. chaperones facilitate translation of structural proteins, and tubulin and beta-actin are involved in virion assembly and release. What was not shown in the picture that I just drew was that the end result of infection is induction of cell survival and cell death pathways in host cells. So ultimately, the coronavirus replication in host cells induces activation of autophagy, stress pathways, and apoptosis, which leads to cell death and tissue damage. Lastly, before we move on to the drugs, I want to talk about the immune response to coronavirus infections. This is worth considering briefly since the vaccine efforts that are underway rely on the host immune system to kill the virus. Research on coronaviruses has revealed several interesting facets about the immune response after infection. It appears that activation of the innate immune system and interferon activity is suppressed by coronaviruses. However, there does appear to be a viable T-cell response. CD4 positive and CD8 positive T cells mount an immune response. CD4 positive T cells trigger activation of B cells, whereas CD8 positive T cells directly kill virally infected cells. And it also appears that CD8 positive cytotoxic T cells are the major infiltrating immune cell in the lung in response to coronavirus infection. CD4 positive T helper cells, on the other hand, appear to be more susceptible to coronaviruses such as MERS-CoV, and this leads to a decreased recruitment of lymphocytes and generation of neutralizing antibodies. In the case of SARS-CoV, surviving memory cells are directed against structural proteins, including the S or spike protein. In fact, there appears to be a key 9 amino acid sequence within the spike protein that elicits the highest B-cell antigenicity. So this is really going to help us understand and explain why so many of the current vaccine efforts are directed against the spike protein, and most likely use this 9 amino acid sequence as a putative antigen to induce an immune response in hosts. Here's our list of drugs, vaccines, dietary supplements, and other therapies that are currently being evaluated for the 2019 novel coronavirus pandemic. This list is not meant to be all-encompassing, but rather represents some of the more promising agents that are furthest along in clinical development. There are a number of other drugs, such as the anti-IL-6 monoclonal antibody tocilizumab, which is gaining promise in Italy, that are not discussed here. As I will say a number of times in this presentation, this is a rapidly changing topic, and what seems promising today may be a failure tomorrow. Let's start off talking about agents currently approved for other indications. One drug that's being repurposed for the treatment of human coronavirus, and that's getting a lot of attention, is hydroxychloroquine. Hydroxychloroquine, also known as Plaquenil, has been around for a very long time. It was first approved in 1955. It has multiple disparate mechanisms of action, including reduction in the number of polymorphonuclear leukocytes, which include neutrophils and eosinophils. Hydroxychloroquine also appears to reduce the ability of polymorphonuclear leukocytes to phagocytose and to generate free radical oxidative bursts, and it appears to decrease chemotaxis. Hydroxychloroquine can also cause alterations in intracellular pH and alterations in lysosomal function, and it interferes with complement-dependent antigen-antibody interactions. So the alterations in pH and lysosomal function are important for one of the primary therapeutic uses of this agent, that is the treatment of Plasmodium infections, the causative agent in malaria. In this case, hydroxychloroquine actually interferes with digestive vacuole function within sensitive malarial parasites by increasing the pH and interfering with lysosomal degradation of hemoglobin. The pharmacokinetics for hydroxychloroquine are quite complex. It's administered orally and is incompletely absorbed. It also exhibits moderate protein binding, about 40%. The onset of action varies greatly depending on the therapeutic use. For example, in the case of rheumatic diseases, such as rheumatoid arthritis, its onset of action can range from weeks up to 6 months for full efficacy to be reached. The metabolism of hydroxychloroquine is mainly hepatic, mediated by cytochrome P450-2A, 2C, and 2D, yielding active metabolites. The terminal T1 half for hydroxychloroquine is anywhere between 30 to 60 days, and it's excreted principally via the urine in a manner that's subject to pH of the urine, and it can be enhanced by urinary acidification. The principal therapeutic use for hydroxychloroquine is for malaria, It's also employed in rheumatoid arthritis and lupus erythematosus. And there are a number of other immunologically related off-label therapeutic uses, including Sjorgen's syndrome and sarcoidosis. Despite being portrayed as being a benign agent, it actually has quite a number of adverse drug reactions. A few of those are listed here, including GI effects such as diarrhea, abdominal pain, nausea, and vomiting, neurological effects such as nightmares, dizziness, psychosis, and seizures, and importantly, cardiovascular effects such as cardiomyopathy and QT prolongation. The cardiomyopathy is notable because this is one of the primary ways that people infected with the 2019 novel coronavirus pass away. One of the most common adverse effects seen with hydroxychloroquine are the ocular effects noted here, including blurry vision, scotomas, and night blindness. However, these are but a few of a very long list of adverse drug reactions, affecting almost every organ system. Other notable, serious adverse effects include Stevens-Johnson syndrome, toxic epidermal necrolysis, angioedema, and many more. At the present time, much of the excitement about this agent stems from a publication showing that the combination of hydroxychloroquine with azithromycin can reduce nasopharyngeal viral carriage and eliminate the virus from patients, but this was a very small sample size, and there are also many issues with the study design that need to be addressed in future studies. For this reason, the true efficacy of hydroxychloroquine in clearing patients of 2019 nCoV remains ill-defined. Our next agent is a combination drug known as Ritonavir and Lopinavir. This is a combination of the HIV-1 protease drug Lopinavir and a cytochrome P450-3A inhibitor Ritonavir, which acts as a pharmacokinetic booster to increase serum levels of Lopinavir. Ritonavir was initially discovered as a protease inhibitor, but it's no longer used for this purpose. The Lopinavir component binds to the active site of HIV-1 protease and inhibits the cleavage of viral gag pol polyprotein precursors into individual functional proteins required for infectious HIV. This results in the formation of immature, non-infectious viral particles. Ritonavir and Lopinavir is administered orally, and it has a moderate bioavailability that's greatly increased with food. It's a highly protein-bound drug, including binding to serum proteins like alpha-1 acid glycoprotein and albumin. It's metabolized in the liver by cytochrome P450-3A4, and this again is the target of Ritonavir. Therefore, this yields many drug interactions. Also, as a consequence, plasma drug levels are influenced by hepatic dysfunction. The T1 half is about 5 to 6 hours with a clearance of about 6 to 7 liters per hour. Excretion is primarily via the feces. As mentioned, Ritonavir and Lopinavir is approved for the treatment of adult and pediatric patients with HIV-1, and the adverse effects include GI effects such as diarrhea, nausea, and vomiting, headache, and alterations in lipids such as hypertriglyceridemia and hypercholesterolemia. Liver enzyme changes, including changes in ALT, are also seen, as well as upper respiratory tract infections. At the present time, early data suggest that Ritonavir and Lopinavir offers no benefit against coronavirus. Now let's move on to small molecules under investigation. An exciting small molecule prospect is Remdesivir, also known as GS5734. Remdesivir has been under investigation for a number of years and was evaluated as a treatment for Ebola in the family Filoviridae, also an RNA virus, but was not successful. Subsequent preclinical work in cell culture and animal models of coronavirus infection, including SARS-CoV and MERS-CoV, have revealed that remdesivir is effective at inhibiting viral replication. Remdesivir is a prodrug nucleoside analog of adenosine that's phosphorylated to the triphosphate form in host cells, and this leads to inhibition of viral RNA replication and inhibition of viral proliferation. Although there's limited pharmacokinetic and adverse drug reaction data available, in a recent study with rhesus monkeys infected with Ebola, remdesivir was administered IV and had a T1 half of about 14 hours. Remdesivir is currently in accelerated phase 3 clinical trials. Our next agent is Favipiravir. Favipiravir represents another antiviral drug that's approved for use in Japan for influenza, but has demonstrated potential against 2019 nCoV. Similar to remdesivir, Favipiravir undergoes intracellular modification to become fully active. Following transport into cells, Favipiravir is phosphoribosylated to favipiravir ribofuranosyl triphosphate by host enzymes. This triphosphate form, also known as Favipiravir RTP, inhibits the RNA-dependent RNA polymerase of RNA viruses, leading to inhibition of viral proliferation. It's given by oral administration and has a terminal T1 half of 4 hours. It's not currently approved in the United States. However, Favipiravir has been tested against many clinically relevant viruses, including RNA-negative strand viruses such as influenza, Rift Valley fever, Lassa, Ebola, rabies, and respiratory syncytial virus, as well as RNA-positive strands like West Nile, Zika, yellow fever, chikungunya, rhinovirus, enterovirus 71, and noro. One of the most notable adverse drug reactions reported for Favipiravir is embryonic death and teratogenicity. Favipiravir has also been reported to increase uric acid levels, cause diarrhea, liver enzyme changes, and decrease neutrophil counts. At the present time, Favipiravir is undergoing Phase 3 clinical trials currently underway in the United States and China. It's also being used in Turkey. Preliminary published results suggesting that Favipiravir is a successful therapy are far from clear. The study listed below compares Favipiravir to a Russian antiviral fusion inhibitor called Arbidol. However, further study is needed. Indeed, the claims made in this paper have been overstated in media reports, leading to confusion about the actual results reported in the manuscript. Analysis of the data in the paper suggests modest improvements for patients, but the clinical endpoints used in the paper need to be more rigorously quantified, tested, and evaluated. Now let's move on to vaccines currently in development. Our first vaccine is mRNA 1273. The pharmaceutical company Moderna is taking a fascinating and exciting approach to develop a novel vaccine for the 2019 nCoV. mRNA 1273 is an mRNA-based vaccine that encodes the spike protein, or the S protein, encapsulated in an ionizable lipid encapsulation formulation. Unlike conventional live attenuated vaccines, which face challenges including rapid development and a general requirement of an adjuvant to boost immunogenicity, mRNA-based vaccines are self-adjuvanting and can easily be scaled in production. However, one of the biggest challenges for mRNA-based vaccines, though, is that they need to be delivered intracellularly. Thus, the vaccine has to be encapsulated in a lipid nanoparticle and delivered intradermally. At the current time, mRNA 1273 is in Phase 1 clinical trials. There is much that's not known about this vaccine, which is being developed together with the NIH. However, at the current time, there are no mRNA-based vaccines approved or in clinical use. Now let's take a look at how the mRNA vaccine actually mediates an immune response. So as I mentioned, the mRNA vaccine needs to be administered intradermally. Following injection, it's thought that the mRNA is then picked up by resident APCs, or antigen-presenting cells, such as macrophages or dendritic cells, at the site of injection. The mRNA is then translated into protein and processed by the proteasome into peptide fragments that are presented via either MHC class I or MHC class II receptors. In the case of MHC class I, these peptide fragments would be presented to CD8 positive T cells, and these would in turn lyse virally infected cells. Presentation of peptide fragments on MHC class II to CD4 positive T helper cells would lead to activation of B cells and production of antibodies as part of the humoral response. These antibodies would be directed against the S protein, or the spike protein. This is thought to be the generalized schema by which the mRNA vaccines work. Our next vaccine is a DNA-based vaccine being developed by Inovio Pharmaceuticals, known as INO 4800. This vaccine is thought to encode the S or spike protein, similar to what we saw with the Moderna-based mRNA vaccine. Like the Moderna vaccine, INO 4800 has to be delivered intradermally, but it's delivered by electroporation using a proprietary delivery device known as Selectra. Much of what's known about INO 4800 comes from the company's website and is also based on the patent application for INO 4700, which was another DNA-based vaccine in their pipeline for MERS-CoV. In the case of INO 4700, it's thought that this DNA vaccine based on the spike protein significantly induced both humoral and cellular immune responses, leading to increased titers of IgG and neutralizing antibodies. At the present time, it's unclear if INO 4800 is based on the same S protein fragment as the Moderna vaccine. Previous controlled trial data exists for Inovio vaccine INO 4700, also known as GL 5300, and this was used in patients with MERS-CoV. In this case, minimal adverse drug reactions were observed, including injection site reactions, headache, malaise, and fatigue. In this study, patients were found to develop neutralizing antibodies in a time and dose-dependent manner. INO 4800 is currently in Phase 1 accelerated clinical trials. Now let's move on to dietary supplements. There are a number of dietary supplements that are being discussed and evaluated. The one that I would like to focus on here is quercetin. Quercetin is a flavonoid found in high levels in fruit, such as apples, grapes, and berries, brassica vegetables such as cabbage, kale, and broccoli, onions, and many others. It has multiple anti-inflammatory actions and immunomodulating actions, and the most significant of these appears to be inhibition of tumor necrosis factor alpha signaling and increased PPAR gamma activity. There are many other potential mechanisms of action. In vitro, quercetin has been shown to affect lipopolysaccharide, interleukin production, interferon gamma production, JAK-STAT signaling, toll-like receptors, and VCAM and CD80 expression, among others. Quercetin is administered orally and has a low oral bioavailability. It undergoes extensive intracellular metabolism, together with liver metabolism, 90 to 95% of which is by methylation, and it's excreted via the kidneys with a terminal T1/2 of about 3.5 hours. The adverse drug reaction profile for quercetin is actually quite clean, although more study is needed. A limited number of studies have revealed that quercetin has the potential to cause kidney damage, but at high doses. It's also been reported that quercetin can cause headaches and paresthesias. Quercetin has been shown to interfere with the entry of SARS-CoV into host cells via unclear mechanisms. There is also some structure-activity relationship data that shows that quercetin can also block angiotensin-converting enzyme. But how blocking ACE translates into effects on ACE2 and effects on the 2019 nCoV entry remain unknown. All of this is very interesting, and considering that quercetin can be obtained normally in the diet by consuming some of the fruits and vegetables noted above, it seems the only downside would be misuse of the information. Either mistakenly think that you could ignore social distancing behavior and go back to normal, or taking exogenously high doses and hastening the onset of ADR. At the present time, clinical data and studies supporting the use and efficacy of quercetin in 2019 nCoV remains undetermined, so it's not clear if it's effective. Now we move on to other therapies that are distinct from small molecules and vaccines. The use of convalescent SERA is a method that's been known to immunologists and physicians for a very long time. This method relies on passive immunization, and it operates from the idea that it's steeped in precedent with other infectious diseases. Convalescent SERA contains neutralizing antibodies that can kill virally infected cells in the recipient. The idea is that antibodies that would be harvested from patients who have been infected with and have recovered from the 2019 nCoV infection may be able to neutralize viral particles or prevent infection in other patients. This technique has been used previously in other viral infection outbreaks. For example, it was used for the SARS-CoV outbreak in 2002-2003, as well as for an Ebola outbreak in 1995. During the SARS outbreak in 2002-2003, an 80-person trial of convalescent SERA in Hong Kong found that people treated within 2 weeks of showing symptoms had a higher chance of being discharged from the hospital than those who were not treated. This method is currently being employed in New York and is actively being evaluated. In theory, patients who were infected with the 2019 nCoV and who recover would be able to make neutralizing antibodies against the virus. These antibodies can then be harvested and administered to patients either prophylactically to prevent infection or to patients who were infected with 2019 nCoV to hasten recovery. Finally, we get to what I've titled Related COVID-19 Pandemic Pharmacology. These are not agents that are being evaluated as therapy for coronavirus, but rather these are agents that have been the subject of news reports, speculation, and social media frenzy. The first area I want to talk about are ACE inhibitors and ARBs. It's been observed and documented that patients with hypertension appear to have a greater mortality and morbidity when infected with the 2019 nCoV virus. This has generated much discussion when considering what's known about how the virus enters the human body by way of the ACE2 receptor in the lungs that I mentioned earlier. This is because most patients being managed with hypertension are taking either an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker. Thus, the natural question arising for this are, do these drugs have an effect on the ability of 2019 nCoV to infect people? Does it make people more likely to be infected due to receptor changes, or less likely? Could these drugs be used to prevent 2019 nCoV infections? Well, like most things in science, the answer is quite complicated. To get to the bottom of this, we need to consider some of the peer-reviewed findings on ACE2 biology. In many reports, both scientific and lay, ACE2 is referred to as the ACE2 receptor. The ACE2 receptor is actually a little bit of a misnomer. ACE2 is an enzyme called a carboxypeptidase, and it's bound to the membrane of type 2 alveolar cells in the lung. It's also found in the GI tract, the kidneys, and the heart, as well as in a soluble form in the blood. It turns out that ACE2 is a distinct entity from ACE. ACE2 converts angiotensin 1 to a 9 amino acid peptide fragment of angiotensin, and it also converts Ang2, or angiotensin 2, to a 7 amino acid peptide fragment of angiotensin. It seems that Ang2 is the preferred substrate for ACE2, and this 7 amino acid fragment of angiotensin that's generated can bind to what's known as the MAS receptor, and this leads to vasodilation, as opposed to vasoconstriction, which is driven by angiotensin 2. It's been noted that reduced expression of ACE2 is associated with hypertension, alterations in cardiac contractility, and increased levels of Ang2. However, importantly, ACE2 is not inhibited by angiotensin-converting enzyme inhibitors at clinical doses. Thus, while it's tempting to think that reducing ACE2 expression might be associated with decreased viral binding to host cells, it could lead to hypertension and affect cardiac function. In addition, ACE2 appears to counterbalance the actions of ACE and protects against lung injury. It's thought that coronaviruses downregulate ACE2, and this leads to lung injury, and this could be attenuated by treatment with ARBs, but this remains to be proven. Importantly, changes in lung expression of ACE2 following ACE inhibitor or ARB treatment have not been conclusively shown, nor has the relevance of such changes been determined. Lastly, you may be connecting some dots here. I had just mentioned a moment ago that ACE2 is found in the heart, and earlier on I talked about how many patients with 2019 nCoV infections die of cardiomyopathy, and indeed many patients begin recovering from the pulmonary effects of 2019 nCoV, but then exhibit decreased ejection fraction and heart failure secondary to cardiomyopathy. It's been previously demonstrated that ACE inhibitors can actually increase the levels of ACE2 in the heart, brain, and urine. So thus it's tempting to think that ACE inhibitors may actually alter ACE2 in the heart. Thus the location of ACE2 in the heart then may have a connection with cardiomyopathy, but this remains unproven. The bottom line is that the current recommendation is that physicians should not alter the treatment of patients taking an ACE inhibitor or an ARB for hypertension due to the lack of evidence related to the effects these drugs have on coronavirus infection. Lastly, there's been some controversial claims made in the media surrounding the use of ibuprofen in patients with 2019 nCoV infections. Initial calls emerged that taking ibuprofen worsens the 2019 nCoV infection. Many suggested that acetaminophen should be used instead. However, there's no evidence that ibuprofen or NSAIDs alter the course of infection, nor the patient's response to 2019 nCoV infection. In fact, based on prior published data, past coronaviruses like SARS have been shown to elevate COX-2 expression and prostaglandin production. And interestingly, indomethacin, also an NSAID, has been shown to block coronavirus RNA synthesis, but independently of COX inhibition. While the significance of these published results seem obvious, it remains to be determined if similar effects will be seen in the coronavirus.